Hello, my name is Dr. Roger Henson. I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome again to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, you can find us wherever you get your podcasts, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes. And if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GP Notebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings, which occur year-round. Now, in this episode, I want to discuss some of the basics of lung cancer, which we should all be aware of in our surgery, because lung cancer is the UK's biggest cause of cancer mortality, with unfortunately nearly 35,000 people dying from this disease each year. And this means it accounts for some 20% of all cancer deaths in the UK and 1 in 7 of all new cancer cases. And it's certainly a salutary fact that 1 in 13 UK males and 1 in 15 UK females will be diagnosed with lung cancer at some point in their lifetime. And despite usually being known as a smoker's disease, around 6,000 people in the UK who have never smoked unfortunately do die each year from lung cancer. If we go globally, worldwide, lung cancer is also the most commonly diagnosed cancer, accounting for some 12% of cancers, and is the leading cause of cancer-related deaths, with some 1.8 million people every year affected. Now, looking at the types of lung cancer, then non-small cell lung cancer, or NSCLC, accounts for some 80 to 85% of them, with this group also including squamous cell cancers, adenocarcinomas, and large cell cancers. Small cell lung cancer accounts for the remainder of all lung cancers, but both types behave very differently in their presentation, metastatic spread, prognosis, and response to treatment. So in general, non-small cell lung cancers usually grow more slowly, spread later, and can often have a better prognosis, whereas small cell lung cancers are typically rapidly growing, highly malignant tumours that spread early and are often inoperable at presentation, along with a poor prognosis. Now, it's no surprise that tobacco smoking continues to be the biggest cause of lung cancer, and in the Western world, up to 90% of lung cancers are directly attributable to smoking, with tobacco smoke containing over 70 known carcinogens. There actually used to be a debate over whether passive smoking contributed to lung cancer, but this question is now resolved, and we do know it increases the risk occurring of lung cancer by some 20 to 30%. Radiation for other cancer treatments and lung diseases such as idiopathic pulmonary fibrosis also increase the risk of lung cancer developing. I think it's also probably worth mentioning radon gas here, as in some parts of the country there's concern about this finding its way into homes from underground. And although radon itself isn't dangerous, it does emit alpha particles when it decays, and this can damage DNA and potentially induce lung cancer as a result. Now, we all know the possible initial symptoms and signs of lung cancer, but for me in my clinics, the big four are cough and/or shortness of breath, chest discomfort, hemoptysis, and weight loss. Cough is present in some 50 to 75% of patients with lung cancer, and hemoptysis present in about 15 to 30%. Chest pain is present in approximately 20 to 40% of patients, and dyspnea may be present in as many as 25 to 40% of cases at the time of diagnosis. I've also learnt to ask about fatigue and fever when I'm screening for lung cancer, and I also check for clubbing, bone pain, superior vena cava obstruction, wheezing, and hoarseness. And hoarseness does suggest recurrent laryngeal nerve involvement. Now, unfortunately, most patients with lung cancer have advanced disease at the time of presentation, and metastasis from lung cancer to bone is frequently symptomatic, with up to 20% of patients with non-small cell lung cancer having metastatic bone pain on presentation, although this may be as high as 40% in patients with small cell lung cancer. Now, I think I'd remind us all here about looking for superior vena cava syndrome with small cell lung cancer. It's not often seen, but I have seen it, and it may be the primary presentation, and it causes dilated neck veins, edema of the face, neck, and upper extremities, and a plethoric appearance. Investigations are reasonably straightforward, I think, and so a full blood count, chemistry screen, and liver function tests, including alkaline phosphatase, should be performed in all patients as baseline tests before starting any treatment. And this can also be helpful in detecting paraneoplastic syndromes, and in metastatic disease, the alkaline phosphatase levels can be elevated, which suggests bone metastases. I think it's really vital too we have a low threshold for chest x-rays in all symptomatic patients, and the more detailed information we can put on a radiology request form, the better, as this facilitates helpful radiography reporting. Do remember that patients with COPD are at a fourfold increased risk, and so I have an even lower threshold for testing in this group. Now, unfortunately for all of us in primary care, almost 1 in 4 initial chest x-rays may be reported as normal or as showing indeterminate findings. So if you have any kind of clinical concern, always make sure your patient has further urgent investigations or is referred on to your local urgent suspected cancer pathway. Now, every patient who is suspected of having lung cancer ideally should have a positron emission tomography CT, a PET CT, before treatment, an endobronchial ultrasound-guided transbronchial needle aspiration to confirm the staging and histological differentiation of the malignancy, and a contrast-enhanced CT scan of the chest, liver, adrenals, and lower neck. Now, interestingly, MRI scans should not be used routinely to assess the stage of the primary tumour in non-small cell lung cancers, but should be used when necessary to assess the disease extent. So, after someone has been diagnosed with lung cancer, the next step is to stage the disease, as this determines the treatment options, morbidity, and survival. And staging is primarily done for non-small cell cancers using the TNM classification, with small cell types also being staged in the same way. Now, as with so many cancers, treatment does depend on the cancer cell type, the anatomical stage, and performance status. Any patients with lung cancer who smoke should be strongly encouraged to stop smoking, even at that stage, and advise that smoking cessation reduces post-surgery lung complications. But, and this is an important point, any surgery should not be postponed until the patient has stopped smoking. If we look first at early stage non-small cell cancers, then surgery is the standard treatment here. And with patients who've got enough pulmonary reserve, then lobectomy or pneumonectomy is the surgery of choice, although this can obviously have significant morbidity. The 30-day mortality rate is approximately 1 to 3% after lobectomy and 3 to 7% after pneumonectomy. Radiotherapy should be offered to all patients with stage 1 to 3 non-small cell lung cancer who aren't suitable for surgery, and chemotherapy should be offered to patients with stage 3 or 4 non-small cell lung cancer and good performance status to help improve survival, disease control, and quality of life. And this is often a combination of a single third-generation drug plus a platinum drug. Now, one exciting development in the treatment of lung cancer, and one which NICE also now recognizes, is that non-small cell types may be categorized and treated according to different molecular subtypes, such as PD-L1, high or low, ALK positive, ROS1 positive, and EGFR-TK positive types. And this last type is more commonly seen in both females and non-smokers. Now, the prognosis of patients with non-small cell lung cancer oncogenic driver gene alterations such as these has dramatically improved with the advent of corresponding molecularly targeted drugs such as afatinib and erlotinib. In fact, I was recently speaking to a respiratory consultant who told me he has now stage 4 lung cancer patients on these types of drug who are remaining well years after diagnosis. And that's a real glimmer of hope for future treatments, I think. The treatment for small cell lung cancers depends on the disease stage. Small cell cancers are very sensitive to chemotherapy, but unfortunately have a high recurrence rate. So, in stage 1, limited stage small cell lung cancer, for example, treatment would be lobectomy followed by adjuvant chemotherapy. And radiation therapy is also indicated here to avoid recurrence, since nearly 80% of small cell cancers will recur locally without radiation therapy. In patients who achieve remission, then prophylactic whole brain radiation is also done, as this increases overall survival. Extensive stage small cell lung cancer is treated with platinum-based chemotherapy, with up to 50 to 60% of patients going into remission, and again, radiation therapy should be offered, followed by prophylactic whole brain irradiation. Now, if we look at prognosis, the most significant factor in non-small cell lung cancer prognosis is the TNM stage at presentation. And as you'd expect, the higher the TNM stage, the more advanced the disease and the poorer the outcome. Other factors that can indicate poor prognosis include performance status at the time of diagnosis, anorexia, weight loss, and the presence of liver or skin metastases. With small cell cancers, the extent of disease and the stage at presentation is the most important prognostic factor here. The 5-year survival rates are approximately 30 to 35% for limited stage and 1% to 5% only for extensive stage malignancy. But I do have high hopes that newer immuno-oncology therapies may improve these rates in the future. So that was a quick overview of lung cancer, and I do hope you found the podcast helpful. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favorite podcast platform. Do feel free to get in touch via social media at GPnotebook or email support@GPnotebook if you have any questions, comments, or ideas for future podcasts. But as always, thank you so much for listening, and until the next time, goodbye.